Okay, so the thyroid gland. This is my rough drawing of the thyroid gland, and you can see that it sort of surrounds the tracheocartilage just below the cricoid cartilage. And I'm sure you can see that from this picture. Anyway, it's interesting because I know when I've taught assessment for folks, a lot of new nurse practitioner students are always frustrated because with our healthy controls, it's very oftentimes very hard to feel the thyroid gland. Interestingly enough, when I talk to the folks that are experts in endocrinology, they actually tell me that it's very difficult for them as well to feel the thyroid, so don't feel bad. Basically, they tell me that if they can feel the thyroid, it usually means that there's something wrong. So, anyways, it's always good to palpate, and if you feel it, then you may be thinking in the back of your mind maybe this thyroid gland is a little bit bigger than it's supposed to be. Anyways, so with that being said, let's get down to the physiology of the thyroid gland. So basically, we've got two lobes of the thyroid gland with an isthmus in the middle, connection between the two of them. And now we're going to get down to the cellular level here. And what we have here I'm going to make this in sort of purple because that's kind of how this tissue stains. We have these little epithelial cells. Um, that kind of make a circle. And inside the circle, we have this collection of fluid. Now outside the circle, we have little capillaries. I'll kind of make them. So you have little capillaries floating along here. Now, what happens is, so what stimulates the thyroid gland to start functioning? It is, of course, thyroid stimulating hormone. So we have thyroid stimulating hormone that is released from the anterior pituitary gland, and it's floating along here in the bloodstream, and some of it comes out of the tissue, and it binds with a receptor on the thyroid epithelial cells. Now, this binding of the of TSH to the thyroid epithelial cells has three effects. It stimulates this cell to start secreting thyroid stimulating hormone directly, and the thyroid stimulating hormone is actually being stored right here inside this collection of cells. This is called colloid, and this collection of cells is called with fluid in the center is called a thyroid follicle. So we have a follicle, and inside we have colloid, and the colloid is filled with a hormone called T4. So one of the things that the TSH binding with the receptor on the thyroid epithelial cell does is it causes release of T4 from the colloid. Okay. The next thing that it does is it causes increased T4 synthesis. Now, actually, the first step, so it increases T4 synthesis. Now, the first step in increasing T4 synthesis is the TSH actually turns on, right on the membrane of the cell, it turns on iodine pumps. Now, iodine pumps are, they sort of work similarly. So, let's draw a little picture of the cell membrane here. This is the cell membrane, and it's a phospholipid membrane, and inside this phospholipid membrane we have a protein. So this is the inside of the cell, and this is the outside of the cell. So we have this protein, and it's working as a pump. And what it does is it's an ATPase pump. So we have ATP here, and then we have iodine that gets pumped into the cell. Okay, so I believe it's 2 molecules of iodine every time it's using 1 molecule of ATP. Now, interestingly enough, this is one of the most potent pumps that we have in our body, so it can make magnificent concentration changes. So we can have, I think, let's see, potassium has a concentration ratio of let's see, I believe it's about 30 to 1, and the concentration ratio of iodine through via this pump, it can be up to 120 times as concentrated inside the cell. So it's very concentrated. Okay, now once T4 thyroid hormone is released into the bloodstream, now T4 thyroid hormone is a lipid soluble hormone. So what do we know about lipid soluble hormones? Well, they don't dissolve well in blood. So in order to be carried in the bloodstream, they need a protein carrier, a globulin carrier, which is typically albumin. Okay, so most of T4 is bound, and only a tiny amount is free. So one of the effects of this is it has a very long half-life. In fact, its half-life is actually one of the longest hormones in the body. In fact, I think it is the longest hormone in the body. The half-life is around 5 to 7 days. And this is primarily because such a high percentage of this hormone is protein bound. Now, interestingly enough, so most of the thyroid that is produced in the thyroid gland is actually T4, thyroxine, but the most active thyroid hormone in the body is actually called T3. How is T3 produced? Well, T3 is actually produced by T4, and it's transformed into T3 primarily in the liver. Although there's many tissues in the body that can transform T4 to T3. Most of it is transformed in the liver. So one of the manifestations of that is if you have a patient. Typically, patients that have hypothyroidism, you can test their level of hypothyroidism by testing TSH levels and testing T4 levels. You don't necessarily need to test T3 levels. One of the times that you'd want to test T3 levels is if you have a patient that is in liver failure. They may have a normal TSH and a normal T4, but their T3 may be very low because they're just not able to transform a lot of it. So that may give them symptoms of hypothyroidism even though they have plenty of T4. Okay. So what are the effects of thyroid hormone? Thyroid hormone increases the basal metabolic rate in our body. So what does that mean? It means that we have an increased rate of chemical reactions, specifically exothermic reactions that are heat generating. So we have increased chemical reactions, and an increased use of oxygen, and increased use of glucose. Now, why do we need to regulate our basal metabolic rate? Primarily, this is to react to seasonal changes. So, we are increasing our body's ability to generate heat. As we change from season to season, as we go from the summer to winter, our body is going to start producing thyroid releasing hormone, which will cause the release of thyroid stimulating hormone, which will cause the release of T4, and this will increase our body's basal metabolic rate. Now, interestingly enough, one of the primary ways that the body does this is, our basal metabolic rate, about 70% of the energy used in our basal metabolic rate is actually used in are sodium potassium pumps. These pumps are so ubiquitous throughout the body, and they require so much energy. Remember, they are sodium potassium ATP pumps. So the body, one of the ways that thyroid hormone works is it actually increases the number of sodium potassium ATPase pumps, and increases the work of these pumps, and that is one of the main ways that we increase our basal metabolic rate and the heat that we are producing in our body. Now, this doesn't occur in all tissues. It tends to occur primarily in skeletal muscle, the heart, the liver, the kidneys, pretty much all. So heart, liver, kidneys. And interestingly enough, these organs all have something in common. These are sort of the big energy users of the body, except for the CNS. The CNS is really not directly affected by thyroid hormone. Okay, so now I'm going to talk about symptoms of hyperthyroidism. Typically it causes thinning of the hair, and I'm not sure the biochemical reason for that. It tends to cause a enlargement of the thyroid gland, and this may be because of a goiter or because of thyroiditis, inflammation of the thyroid gland. It affects the heart. Now remember, it's sort of increasing the metabolism of lots of organs, so it's going to cause tachycardia. It's going to cause hyperreflexia, and it tends to cause diarrhea because of increased peristalsis. So we have increased peristalsis. This is a little picture of the colon. Okay. So it's going to cause cramping and diarrhea. It's going to cause sort of warm skin and sweaty palms. Actually, they're going to be sort of warm and sweaty everywhere, and they're going to tend to have heat intolerance. So they're not going to like the warm summer days. And they tend to develop pretibial edema. So swelling. Now, interestingly enough, one of the symptoms that's associated with hyperthyroidism is actually not caused by hyperthyroidism itself, but we'll talk about it in a little bit. And it's exophthalmos, so the eyes that are bulging. Okay, so what would happen with hypothyroidism? A lot of the opposite things. Now, you don't get thicker hair, but in fact, actually, you can have some hair loss with hypothyroidism, but the hair becomes very coarse and brittle, so it tends to break. You end up with sort of edema around the eyes, so periorbital edema and swelling of the face, facial swelling. And typically you'll have usually a normal sized thyroid gland, or it may be smaller depending on the disease. You're going to have constipation because you're having slowing of the gut. And you're going to tend to have bradycardia. And you're going to be shivering. because you're going to have cold intolerance. Actually, you're probably not going to shiver, but you're going to feel cold. Um, so cold intolerance. Now, interestingly enough, hyperthyroidism is sort of associated with weight loss because you're using more energy. And hypothyroidism can lead to weight gain. Now, interestingly enough, probably in this day and age, one of the major causes of hyperthyroidism is actually someone getting a hold of Synthroid, or synthetic thyroid hormone, and they're taking it in order to initiate a weight loss. Now, this is a really bad idea because it has so many side effects. So if you have a patient that comes into the ED that has heat intolerance, hyperreflexia, tachycardia, and edema, and they tell you they're trying to lose weight, then you may suspect that they may be taking Synthroid. Okay, so one of the most common causes of hyperthyroidism, I'm going to talk about hyperthyroidism first, is actually a condition called Graves' disease. Now, Graves' disease is a very interesting disease, an interesting autoimmune disease, because here I'm drawing a little picture of a thyroid follicle again. And we've got a little receptor on the thyroid follicle. And this receptor is going to get turned on if, there's TSH present, right? So TSH will come along, say, got these little TSH particles, and they'll connect with this receptor. But interestingly enough, with Graves' disease, what we have is an immune globulin that has an end on it that has a structure exactly the same as TSH. So this immune globulin comes down here and actually binds with this receptor. So this causes a typical autoimmune response, and it causes inflammation. But because this portion of the immune globulin is mimicking the TSH particle, it actually stimulates this receptor. So what happens when you stimulate the receptor on the epithelial tissue of the thyroid gland? You increase the secretion of T4, and you increase iodine intake, and you increase the production of T4. So it's a very interesting autoimmune disease because not only is it causing inflammation and damage to the tissue, but it's also stimulating release of T4 because of how the portion of the immune globulin actually is mimicking the molecule of TSH. So again, this is called Graves' disease. Now, Graves' disease, these immune globulins can actually attack some other tissues too, and one of the tissues that it tends to attack is, let me switch that to white color. One of the tissues that it tends to attack is the tissue behind the eye. So there's like some fatty tissue behind the eye, and this immune globulin binds with some proteins that are sort of suspended in this fatty tissue behind the eye, and it causes inflammation back here, and that is what causes that exophthalmos. So there's no direct effect from too much T4 that causes exophthalmos. It's actually a separate mechanism from inflammation behind in the orbital socket that is causing it. Okay, so what are some causes of hypothyroidism? Well, interestingly enough, there's three different types of hypothyroidism. There's primary, there is primary acquired, there's primary congenital. That means you're born with it, and then there's secondary, which is caused by problems with the pituitary gland. Now, one type of primary acquired hypothyroidism is an autoimmune disease called autoimmune thyroiditis or Hashimoto's thyroiditis. Now, interestingly, this disease, is caused by an attack on the epithelial cell receptors for TSH. But these little Ig, these immune globulins, don't have an end that looks like, they don't have an end that mimics TSH. They just have these other little ends. So what happens is it binds with these receptors, but instead of activating the receptors and causing the release of thyroid hormone, it actually destroys the receptors and causes damage to the entire thyroid gland. So this is called Hashimoto's, and it is a form of primary acquired. So, it's similar to Graves' disease in that it involves an immune globulin that is binding with the TSH receptor on the thyroid epithelial cells, but it has a very different effect. Whereas in Graves' disease, the immune globulin is actually activating that receptor. With Hashimoto's thyroiditis, it's binding with and destroying that receptor and causing cell damage. So Hashimoto's, what happens is the thyroid tissue becomes inflamed and then eventually becomes destroyed. So you end up with thyroid gland atrophy and destruction over time. So what are the causes? Well, we know that there is a genetic predisposition. It happens to occur in certain population groups more than others, particularly East Asians, with Japanese ancestry. Now, there are other types of primary acquired primary acquired hypothyroidism. Actually, the most common, Hashimoto's is fairly common in this country, but one that's the most common in the world is actually just called endemic goiter. And this is due to, in order to make T4, in order to make thyroid hormone, we need large quantities of iodine because iodine is a critical element. Now, people around the world oftentimes have foods that have limited supply of iodine in their food. Now, back 100 years ago, we had the same problem in this country because we had our food. Actually, it happened quite commonly in Western New York because we're an area that has low iodine concentrations in the soil. So people in Western New York would frequently get goiter, as they would in other parts of the country. But then, Congress passed a law and decided that the way to cure this is to put iodine in salt, and that gave us constant iodine supplementation. Interestingly enough, now that we get our foods from all over the world, in the United States, we no longer need iodine in our salt anymore because we get plenty of it in our food because our food's coming from Chile and California and Florida, so we get plenty of iodine. We're not dependent on a local food base. However, in other parts of the world where they If people live in an area where there is not a lot of iodine in the soil and they don't have iodized salt, then they're going to end up with endemic goiter, and they're not going to have sufficient iodine supplies to create the thyroid hormone that they need. Okay, and then there are congenital causes of hypothyroidism, and that is just going to be caused by thyroid tissue that fails to develop appropriately, or thyroid tissue that's incapable of producing T4 because of a genetic abnormality. Okay.